This is Lane, and she's a quadragenarian, so she's in her early 40s, and we won't go into too much detail of what are all the positive things are, but we'll maybe just do that a little bit. What are the best things about your face?
I'd say my jawline and maybe my cheekbones.
Okay, so she says her jawline, which is awesome, and her cheekbones are great. And if you have anything done to your nose, so we're going to talk about that a little bit. Suck through your nose a little bit. Okay.
Let's draw it up in a way.
And what things have you had done for your face? What treatments have you had done?
Neurotoxin.
Draw it up using a
I had my
27
cheeks
gauge
done
needle.
about a year ago.
Had your what done?
Cheeks.
Okay, so she's had cheeks. She's had some cheek filler done. How about your jaw? How about your lips?
Nope, never.
Okay, and when was your last Botox done?
Like last week.
Last week. Okay, scowl a little bit. Okay, and do your bunny nose.
I do need that.
All right. So where's my pencil here? Let me have my pencil. Anybody see my pencil? Here. Here we go. Thank you. Let me see my pencils here, guys.
Which pencil are you looking for? White one or what?
No, brown one.
Oh, I must have.
I got it.
You got it?
Got it.
It's in your pocket?
In my pocket. I carry my eyebrow pencils with me everywhere I go. Just in case you wanted to know. Do you think
in case
you're
go
just so you're not the only quirky one?
Well, you go out clubbing late at night, so
Yeah,
you need that eyebrow
sure.
pencil.
So what things would you like to see better?
I want just define more. Or it's too defined because of my massive.
Okay. So if you lean forward a little bit, clench your teeth. Now she could break walnuts here. Like, have you had your master's treated before?
About a year and a half ago.
Okay, now open your mouth here a little bit. Okay. Are you breaking teeth?
No,
Let's see. So are you grinding them at night?
a little bit.
Yeah, you are. You're grinding them at night because she's got worn off tops of her teeth here, so she's definitely grinding them.
You can
Me?
grind during the day.
Oh, of course you can grind 24 hours a day. I have 24-hour grinders, and but a lot of the grinding is done at night.
Great.
Then you're not quite aware of it. If you got a partner you sleep with, I'm not getting too personal, but does they aware you
Trust me.
grind?
No.
If you have
yeah,
kids,
where?
you grind day and night.
Yeah. So do you get headaches?
It's going to kill me.
Slightly.
So she gets headaches because she has temporalis enlargement as well. So her temporalis muscle is enlarged. So she's a bit of a clencher, and she's a bit of a grinder. So what side does she chew? Don't tell us. What side do you chew on?
Let's get her face up a little bit. Just look up at the camera, Lainey, if you don't mind. The camera's sort of hovering above you a little bit, so look up at it. Atta girl.
Come on, quick. Which side? Right side. She chews on her right side. Correct?
Correct.
Correct. Okay. So I wasn't born Sherlock Holmes III for nothing. So that side,
Elementary,
and
my
sometimes
dear.
it's hard to interpret the side that she's clenching on here a little bit. Now with her animation, because we talked before, if you may have been listening a little bit, we don't know all these animations we do because we've only seen ourselves in a mirror or in a photograph unless you're identical twins, so you don't see all these little quirky things we do. But one thing, have you ever had your bunny lines injected with Botox?
Yeah.
Have you?
Hasn't been a while.
Okay, and it hasn't been a while because she's got these little bunny lines. Now, what happens with bunny lines, there's a little interesting trick here. So if you, instead of watching the bunny lines, watch her lower eyelid. Okay, do your bunny lines. And so she gets these wrinkles around her eyelids. So if you want to make a happier patient, you do neuromodulators on her bunny lines, and these eyelid wrinkles go away. So, in fact, some of you asked me that last time we were here. If you've been trying that, we do that several patients a day, primarily for the lower eyelid wrinkles. So we can maybe talk about that a little bit, Arthur, when if we do any neuromodulator there. Botox equivalent, this is a very active muscle, so I'll usually use 6 or 8 units on each side. It takes quite a bit of units for that to work. Now so what other things would you like to see better?
I want my cheeks.
Yeah, other things beside that.
Oh, maybe a little more lip.
Okay.
I've never done my lips before.
Well, we can talk about that a little bit. So let's measure her. Now, what do you think about her forehead height? Is it high or low? Okay, so
Lainey, how do you wear your hair?
how does she wear her hair?
Usually down.
Usually down. So
Usually
her
down.
brain knows just intuitively that she's going to wear her hair down. So if we just do a quick little measurement, you can use that one too, but I'll use this one. So if we look at that distance, remember, between the eyes, and you could almost fly with those eyelashes. They're great. Okay. Let's see here a little bit.
Fuller brushes.
You can't do that with Latisse. So that distance between the eyes, that intercanthal distance, should be that distance between the brows. And that tendency now for the brows to sort of be focused a little bit more medial is quite popular, and it depends on if you like that look or not, but it's a little bit medial. And that should be the width of her nose and the maximum volume of her lower lip. And the phi part of this should be the length of her brow. So who shapes your brows?
They're microbladed.
Okay, so the microbladed, which, it's quite obvious that's been done, but it's been done very well. So whoever has done that has got a good eye. So that should be the length of her eyebrow. And the height of her forehead mid-pupil. And as we said earlier, either you get a chainsaw out or you do modify her hairstyle. So I noticed her hairstyle before. It was very nice on you. It looks really good, really good. So and then the length of her nose, keep your eyes open if you can keep those open with those eyelashes. So
He's not letting go of that lady.
So the length of the nose this is why sometimes I don't use the eyelashes, because you might be up there with her nose. So that length of the nose is actually right on, but her nose is a little bit wonky. She's got the dorsum of the nose, a hump to her nose there. And it's okay. Is that your mom or your dad?
My mom.
Oh, you sure? You get all the bad stuff from your dad, so.
Any surgery there at all?
Yeah, no, she's had no surgery.
No surgery.
I
That's
wondered
great.
that because do you have an injury here at all? Okay. So you could improve that just a little tiny bit with a little bit of filler just to adjust it a bit. And when you talk about fillers for noses, which I'm sure Arthur does the same as I do, I inject probably 6 or 7 noses a day. And almost every patient thinks you're going to make their nose bigger because you're adding a filler, right? So if you add a filler, you must be adding volume. And of course, you're not. You're creating shape. So sometimes that's the last thing I do before the patient leaves. So you've got a little, even in your new patient, just creates a little confidence. So the apex of the cheek should be, and there's several ways to draw that. Arthur's already been through that, but that should be the length of the brow from the corner of the eye out 45 degrees. I think your cheeks are fantastic. As she mentioned that, she already knows intuitively that's really good for her. And then the peak of the brow, not apex. The apex is cheek and peak is the brow. Should be from, and sometimes you don't measure it from here because she's got this blading a little far over. So you measure it from the inner canthus, and she's got this peak just perfect. So I think her peak of the brow is very nice. And she doesn't have temporal hollowing. She has hypertrophy. So if anything, you'd want to shrink this down, clench your teeth a little bit. So when do you get the headaches here? Is that nighttime or?
During the day.
Yeah, it depends on what's happening. Okay. So when do you find yourself clenching?
I don't feel like I do.
You don't feel you do it. You don't know you do it. Well, most of these little habits we don't know. So that length of the brow should be the width of her lips here. We'll make sure that hasn't changed. And with your calipers, always double check. Keep your eyes open there. I won't stick you. So that distance should stay the same from 14 to 100. And by the way, the first 100 years are the worst. And then like that's good, perfect. And then her chin, you can measure that intercanthal distance, or you can measure it this way. Depends on what you're trying to do. Her little weak spot that shows up as a quadragenarian is this prejowl sulcus here. And she's such a smiler. She really has this nice tendency for her corners to lift up. So I wouldn't address that too much, but it's her masseters that are kind of the issue here. So what I would do is we'll just draw this out a little bit. And the drawing you can vary a little bit. We draw this a little bit different, but essentially it's the same concept. Keep your eyes open here. So from the lateral canthus here to the tragus, mid-tragus, corner of the mouth, down here, and then you want to draw this little circle around like that. And it helps you define this cheek mound. And you could go like Arthur does, a little bit higher, but it's still really the same premise. So the lateral canthus to the mid-tragus here, what I'm trying to draw. Okay, what side of the face is bigger? Because each side of the face are not twins, they're siblings or sisters. So what side's bigger? The right. The right side's fuller, just subtly. So she's just a little bit. And asymmetry actually gives you a character. We don't want to make you perfectly symmetrical. You'd be intolerable. So what we do is just we'll draw along her jaw angle here because she's got quite the gonial angle. And she's been doing this for so long, she's actually stimulated mandible. So unless you had a third-dimensional view that I have, you wouldn't appreciate how big this mandible is. And you're a pretty petite girl to have the size of the mandible here. So this pencil you can almost blow off, so we're not going to have any drawings left here for you. So let's take this off on her cheek here for a minute. Just take this bottom line off for me.
Lainey, do you want your masseters injected?
What's that?
She wants her masseters injected, so you're just going to circle where you do the injections, Kent?
I'm just defining the mound of her cheek is all I was trying to do, is just define that mound.
But you're going to circle where you would put the
what I'm going to do is outline her masseter here.
Right.
So let's just blot this off here.
He'll be the brains and I'll be the hands. I'm wanting to plan this patient the way he would do it.
Okay, so with her masseter, let's see if you can see this, Arthur. See from here. I'll go this way maybe a little bit to see. Just turn this way a little bit here, Lane. Okay, that's good. Okay, can you see that a little bit better? So clench back and forth here. Clench back and forth. Okay, so mark the front part, as Arthur's been telling us here. That right in front of the masseter is where the facial artery is here. So here's the facial artery, just about a centimeter in front of that. So you're safe to kind of go that far. And then if you're going to mark out, say, where Stenson's duct is, the parotid duct, it comes up through here to the middle of the upper lip. And the risorius muscle is about this angle here. So when we draw this masseter out, keep it tense now, keep it stretched there. This is how big her masseter is. So it's a big muscle. So I would inject actually 4 different places here. So it's superficial and deep, and the deep one lies in this boundary here. You can actually see it underneath the skin. And it comes underneath and wraps underneath the mandible. That's what creates that extra power, is underneath that mandible. So I would inject, clench again here. Okay, good. I would inject here, here, and here. I don't know about you, Arthur, but that's where I would inject her. I mean, it's hard to see on that picture, but that's where the deeper one is here and the superficial is here. Then you'll get the muscle. Then you'll get the whole thing. So as far as fillers are concerned, she doesn't really need much here, Arthur. I would do just a little bit in her lateral commissure, pre-jowl sulcus, marionette zone here a little bit. And you might consider straightening out her nose a little bit because it's a little bit wonky. That's the only wonky thing about her there. Okay, Arthur?
Yeah, sounds great.
Do you want to take that all off?
Yeah. What I'll do is...
We'll talk about her lips too, because you could do a little bit of enhancement of her lips. Now she's petite. If she had Angelina lips here, she'd look ridiculous. So all she would want is a little definition of her lips. And you want to look, she's a good example if you want to look at her photo when she's 20 or 30, and she probably didn't have much of a Cupid's bow, did you?
No.
Yeah, so she didn't have much of a Cupid's bow. So to create one would be not a good idea.
Okay, so I have toxin over here. The toxin that I have is loaded into a 1 cc syringe instead of a BD2 because I want the half-inch needle, as Kent was telling us, for the 30 gauge half-inch. I agree with his assessment and his location of injections. If you want to stay safe in masseter, you must be at least a centimeter behind the anterior portion of the masseter so you don't touch risorius. Rhizorius' origin is off the masseteric fascia. Okay? So you want to be at least a centimeter behind. If you start to encroach on the anterior border over here, you'll catch a bit of Rhizorius, and she won't be able to open her mouth wide when she smiles. And as Kent was mentioning, those things last a long time. They can last 2, 3, 4, 6 months.
Mm-hmm.
So you don't want to do that. So you palpate always, and she's giving me, look at the way she's bouncing around here.
Yeah, see, that's the deep one she's bouncing.
Correct. So there's 3 different layers to the masseter, a deep, intermediate, and superficial. Okay? What you want to do is you have to hit the deep portion because that is the strongest portion of the masseter. The superficial portion is just there to tense over the deeper portion so that she doesn't herniate or bulge, which is that beautiful case that you showed us. When that's what's happened before? Yes, when I started doing masseters, the first masseter I did, I got this walnut that stuck out. I went, what the hell is that? And then I realized that what happened is that the medial and deep portion had actually herniated through because there was nothing of the superficial to tent it, to keep it from coming through. So that you go ahead and you must inject deep. That means just about down onto bone. I do the exact same pattern that Kent was talking about. For the bulk of the muscle down over here, I would put 3 injections in, and I'll put another injection up towards here in the middle part, where look what she does to my finger. Okay.
Yeah, it's deceiving how powerful that is.
So,
and I even though we're going to do it correctly by experience being the way we've done it for years, is she still may, for the first 10 days, herniate that deep one, but that'll settle down. You just encourage her that could happen. I usually show patients pictures of that a little bit so they can understand how that's going to happen.
If you're just starting to do masseters in your practice, this is what I would suggest. Draw a line from the commissure down to the where the earlobe attaches to the ear. We used to say to the tragal notch, but now where the earlobe attaches, draw a line like that. Draw your anterior border and your masseter over here. Stay 1 centimeter back and concentrate all your injections over here. You might miss a little bit of the superficial part of the muscle, which will go back, but it's a much safer area to inject originally when you're down here low and away. Once you start getting up over here and a little bit higher, okay, you run the risk of having some other issues that can occur over there, especially when you're talking about the very upper portion of parotid and things like that, that you have to be very careful of. So like we said, the Rhizorius muscle is coming from here and heading just like Ken drew it across over here. Okay? I put in on her, because we're going rather conservative. What I do on Caucasians and Asians is different. On Caucasians, I start off with about 30 units. Each side.
Botox equivalent.
Botox equivalent. So it's Inco or Ano. And for Abo, I put in, so we'll be talking about for Botox or Xeomin, I'll use 30 units, okay? And I'll use 75 units of Dysport, if I'm using Dysport, okay? So we treated that side. I'm cleaning her up over here. I'm going to do a couple of little things with her. Let me have the toxin for the other side too, please. 40. I learned that from Waffles. He puts in 40 every month. He just keeps hammering away at that until that thing disappears. Okay? I think what Kent has done, which is remarkable and different, is the fact that he's combining the functionality of the muscle with the dosage and with the way he treats. Because he's going after the click. He's going after the grinding, the clenchers. Whereas what Waffles does is he's going after facial shaping. So Waffles wants to completely obliterate anything because there's so much width to the face in Asians just with their bone structure, right? So we're going to clean this up over here. I'm going to see if I can show you. Is she a 4 syringe candidate, folks? Okay. Is she a 3 syringe candidate? So she's what? 1 or 2? 1 or 2. I agree. So you say 2, you say 1. She comes in, she says, I only have a budget for $700 because I think that's what you charge per syringe. What are you going to tell her? I have an idea that I can do something beautiful for you, but it's not going to cost $700, it's going to cost $950. And she's going to say, $950 from $700? Why? How much are you going to use? I said, whatever it takes. You know you're using 1 or 2 syringes. If you get it with 1 syringe, hey, you just pocketed $250, but that's not the way you look at it. You do it until you're happy with the injection. And she'll walk out a very happy camper.
Watch this, watch her there.
See that? Look how anterior that is.
She's just doing it as a habit there. Do you want to mark it out, or do you want to just inject?
Yeah, let's mark it because that's the proper way to do it. So here's the anterior border of the masseter. Here's the actual jawline over here. If you want to draw that line that we were talking about, here's the line that comes across. So if you stay in the bulk of the masseter, which is over here, you're going to be safe, but you don't want to be within a centimeter, so I have to be back a bit. Ready? So we're going to inject right back over here. I'm going down deep. You can't do that. You cannot do that with a BD2. Here's the second injection.
And notice he's not clenching. If you clench and inject, it actually hurts.
Yeah.
So that shouldn't hurt you too much, right?
There you go.
Yeah, you don't. Oh, she's pretty disciplined.
She's very good. Didn't even flinch.
Yeah, she's disciplined.
Sorry?
Just wait.
Go, Lainey, go. Wait, we'll beat her up. Don't worry. She ain't getting away so easy. Okay, Kent, what would you like me to do next on her?
Well,
You talked about nose. I can do a little bit of injection on nose. Let me have...
I would like to see her nose.
Yeah. So let's look at her on profile while we get some nose stuff done.
Your nose?
Can I have the ultra?
No, just a little
plus?
tiny bit. We're talking tiny bits on her nose there because she's got...
Right, it's very tiny. Very tiny.
If you just, let me have a little cleaner there, just a little draw to my
See
finger
if I can
here.
convince her to do something.
I put a little bit on my finger. Here, just okay.
You, boo-boo.
So what you want to do is let's just see reflected light here on her nose here a little bit. So you put any kind of liquid on her nose here. Arthur knows this little trick here because he does lots of rhinoplasties, or he used to do lots of rhinoplasties.
Still do.
So what I've done here, Arthur, is just trying to create reflected light here a little bit.
That's exactly right. This is what we do in the operating room. What you do is you stand behind the patient, you put a little bit of a wet gauze down their nose, and you take a look and see where the light reflects. And it will tell you, I'm going to try to tilt her a bit. So, oh, there we go.
Yeah, see there, see.
Okay. So you can see that she has a little bit, it comes down, and then it sort of
has
does.
It turns over to South Beach right there. On the end.
He's relentless, you know that, lady. Okay. So that what you're trying to do is to line that up. She also has a little bit of flattening of the pyramid over here. Okay, so her nose comes up and it flattens a bit over there. We take a look at her profile. She's got a beautiful profile. Okay. Really a beautiful profile. I'm sorry about this. I'm going to do this to see.
Yeah, just a little bit. She's just got a little.
She's got a little teeny bit of a hump over here.
Yeah, I wouldn't touch the hump, but below it and above it. Can we have your gum? You don't have any gum in there? Okay, because we need to send you to gum reformatory school. So you're chewing gum usually?
All the time.
Yeah, all the time. See, Hubba Bubba.
Hubba Bubba.
Hubba Bubba Reform School. It's actually crowded. You can't get in. There's a waiting list.
So, if you want to understand...
Also going to give you a bad time.
Okay. When you take a look at the where the nose takes off from the forehead, which is called the nasal frontal angle, or the radix or radix of the nose, you can do it by, as Kent was saying, by the
trade your pencils.
Yeah,
that was too black.
Yeah, by the tarsal fold. But what I like to do is I like to look at the limbus of the upper eye. So it's the lash line not where the lashes are, but where the lashes originate from. Open up and look into the camera. Okay, look a little bit straight ahead at this pencil and stay right there. So it's about this level over here, and I'll draw it across over there. What does that mean? It means that if you turn the patient's head and you see that little bump over here, that you can give her a little bit more of this elevation over here to soften the bump. But if the bump is already up to that line, don't chase it up to the forehead. You're going to make them look masculine because the nose doesn't start from the middle of the forehead. All nasal injections for everybody, if you want to stay as safe as you possibly can, the nasal injections are midline. You stay smack in the midline because the dorsal nasal arteries are paired and they run on either side. So you want to stay on midline, and you want to stay deep. You want to stay on the bone. You're either on periosteum or perichondrium. Everything in between is dangerous. Why? Because it goes skin, subcutaneous tissue, muscle, fibrovascular layer, then a gap. That's the gap just above the periosteum, and then the periosteum itself. So if you're down on bone, you're beneath the vessels. There's an intercanthal artery that's right in between the two canthi over here. That intercanthal artery is sitting in the subcutaneous tissue. It's running between the two dorsal nasal arteries, and that intercanthal artery has been implicated in bilateral cases of you-know-what, which we're not going to talk about, and so you don't want to be anywhere near it. So we're going to go ahead and we're going to inject just a very small amount of product, very slowly over here. She's nervous. I got her already thinking about it. But we're going to turn her head slightly to the side, and I'm just going to go ahead. Yeah, she's good. She's fine. And I'm going to give her a little pinch as I go right down onto bone. My needle can't go any deeper. I'm going to inject very slowly. I'm watching the dorsum, and I'm watching her glabella as well. Are you feeling a lot of pain, Lainey? Nobody's asking me the question.
What's the product?
There's the question. The product that you want over here is a product that I use that's very cohesive. Okay, you can see that I've created a little bump over there. Do you see that? I want a product, and that's it. I want a product. Oh, you're so happy that I'm finished, huh? Okay. How many fingers? Okay, just kidding. Okay. You want a product that's very cohesive because you don't want a product that spreads over the nose at all. And you want a product that has some stiffness to it. What do you like to use over here, Ken?
I'll use Volift, Voluma, or Restylane.
That's pretty much what I do too. I'm using over here.
You use such tiny amounts, you just want to lift.
Correct. And I'm using over here Ultra Plus, actually. I like Ultra Plus because it stays nice and narrow.
If you're doing Asian nose, which you do a lot of, you want to actually hold it there between your fingers so that it doesn't splay out. You want to lift and not lateral spread. So you want to hold and inject at the same time.
This is your Da Vinci signature on the face. Why is it your Da Vinci signature? Because what you're doing, which he never signed anything. Isn't that interesting? It's true. He did never sign anything, and he actually slept with the Mona Lisa next to him until his death. So that's not the actual Mona Lisa, but the painting. So the reason
because he was gay.
As are all great artists, I guess.
That's true.
So if you put pressure over here, what you're doing is you're contouring that part, which is not straight. It's not avatar. What is it? It's curved over here. So this over here is your signature because it's the inside curve of your pulp. Yeah. So she has no bump left at all now. Look, it's gone.
So we don't touch the bump, but the bump disappears.
And that took literally 0.02 or 0.03 of product. This is pure. This is absolutely pure. I would use pure product over here because you want to get the product to be able to lift as much as you possibly can.
Ultra? Yeah, Ultra Plus.
Ultra Plus pure. I could have used Define pure. I could have used Lift pure. Okay, we'll do it on other patients. Okay, it's really what it's all about.
You can use something like Volift. We call it Volift in Canada, but I think it's good they changed the name to Volura because Volift doesn't lift. And Voluma lifts well. They got the names backwards.
Didn't feel it?
Volift is a great product. Volura is a great product, but it's not as good a lifter as say, Voluma.
Sills or not? Do whatever you want to do. Okay, guys, I'm going to try something a little bit different now. We're going to go back to the Resty.
Oh, Lane, you're in trouble now.
Oh, you're in trouble is right. Let me have the Resty silk that you had before. You have it over there, I believe. And put it into a BD2 for me, please. Stay midline on the nose all the way down. Okay? It's when you vary off midline, and that's where we've seen cases of blindness with respect to cannulas, is because if you go in with a cannula and you go lateral a little bit, you'll cannulate that lateral dorsal artery, which will come up and connect to the supratrochlear. And so you can get the retrograde flow. So I believe in vertical puncture down on bone in the midline. Can you wander off the midline? If you're an expert injector, Kent and I have recently submitted a chapter that shows how you can handle nasal valve collapse by injecting laterally over here in the area where the collapse is, but you must be intradermal. If you go underneath the dermis, everywhere you see a crease, there's a vessel underneath in the nose. That was a paper published by Rorik and Pessa, Joel and Rod. Okay? So what you want to do is, if you're injecting anywhere off of the midline, you got to go intradermal. But remember,
and vertical.
These are end arteries over here. You can cause a little bit of an ulceration if you're not careful. Same way that you get an ulcer on your butt by sitting on it all the time. If you're paralyzed, if you go ahead and you inject over here, there's no help from friends, so you got to be careful. What I noticed on Lainey that I thought I would ask her if she'd allow me to treat, let's take a look at her face over here, is when I look at her straight on like that, the thing that I notice that's distracting to me is the fact that she has a lot of nostril show. Mm-hmm. If you look at her from the profile, she should have 2 or 3 millimeters as most of columellar show over here, but she's retracted back up. Typically seen post-rhinoplasty, because if you make an incision on the inside of the nose over there in an endonasal approach, when it heals, it may actually retract up the nose. And if you take out cartilage over there, you add that system of removing structure over here.
That's why we both asked her if she'd had a
right.
rhinoplasty.
And when she smiles, she pulls it up. I think she would look better if we could drive that nostril down.
Just a little bit.
Should we?
Yeah. Oh, yeah.
You're the ones that are calling it. If they had surgery, I would do it again, but I would be very careful. Any nasal injections that I do in my practice, the patient stays in my practice for 15 minutes at least afterwards. Read a book, whatever the story is, because I always want to make sure that there's absolutely no issues. This injection is for advanced injectors. What you're dealing with over here is you're dealing with, skin-to-skin apposition. The lower lateral cartilage, which we call the alar cartilage, is shaped like the wing of a gull. And you can see it on her. This is the medial crura. As it comes up, it forms the bulk of the dome.
Then it goes to the lateral crura.
Then it comes up over here. And it has a little tail that comes down over there. This is her beautiful dome. That little tail over here, which is very thin in her case, is why she may collapse a bit, is holding her nostril open. But the tail stops right here. Okay? So from here to the edge of the skin, it's a sandwich without any filling. It's dermis on dermis. You have to be inside the dermis to dermis to do that. Ready? Mm-hmm. Good girl. It's a little sensitive, but I'm going to be very, very gentle with you, okay? Mm-hmm. I retract the nose
Watch
like
what
this.
he does here. Watch.
Retract
close.
the nose. And I fire it back in.
The nose fall on the needle.
Okay? I start my flow very gently. You're okay? Mm-hmm. Here's my flow. Look at the blanching that you get. It's a little sensitive. And I'm going to eject. You're okay? Mm-hmm. Breathe it through.
You can walk on the hot rocks in Tahiti after this is done.
There you go. And I'm going to gently advance my injection. Slow injection. Very slow injection, Lainey. You good? Mm-hmm. It's going to make you tear, sweetheart. I'm sorry. In fact, there's a reflex of tearing over here. Sometimes it's not even so much the pain, but it's actually the reflex of tearing. Look how slow my plunger is moving. And I'm injecting only a small amount of product.
And there's different products you can use here. We can use silk, and you can use, you're using... I
have to do the other side
too,
unfortunately.
Extra Juvie.
Close your eyes. How do the actors cry when they want to do it on demand out in California? They don't stick a needle in their nose. What do? You're getting closer. They don't pinch their nose either. What do? Sorry? That's right. They pluck a hair out of their nose because it's an automatic reflex that you start to tear. They'll turn away from the camera. They'll pluck a hair out of their nose. They turn back. They're tearing. They're crying.
Needle works better.
Right. So, Meryl Streep has a bald nose. Let's get that camera
Extra,
looking
same
over
thing.
there.
You could use silk here as well. Silk's a good product for there.
Okay, let's put your head back. Okay, look at the difference now. Do you
silk
see the difference?
Yeah, uses blended silk there. That's kind of what I would have used.
Take a look. Okay. You see how this one is coming up? Imagine if you have a patient that has a peaked nose. If they have a real notch over there, there's nothing surgically that I can do that. I did my fellowship with a guy who was really a master at rhinoplasty, Dr. Millard. That's from down here. He was from Miami. Okay? And he had this technique where he would flip the skin on the inside of the nose and pull it down and do all these crazy things. I was never able to duplicate it. But this is the nuts. If you get a patient that has a retracted nostril after you do a rhinoplasty, my reoperation rate, look at the difference in the height of the nostril. My reoperation rate has dropped right down on rhinoplasties. In fact, when I take the splint off on a patient after a week, if I notice there's a little irregularity of the dorsum, if I've overfiled or over-resected the dorsum, I fire in at 1 week a small amount of Restylane or a small amount of Ultra or Ultra Plus, just to act as a little strut to keep the skin up. And with the bruising and the bleeding and the blood that goes in the fibrous amount, I never have to inject them again. It's done. It's finished. So my reoperation rate, thanks to fillers, has gone right down. Okay? But you see the difference there now, guys, huh?
Yeah.
Okay. That lasts a long time. Sure. Let's turn the other way now. Okay. Okay. So we're only going to do one side.
And you could use a blended velour here as well. It works really well.
Can you breathe in?
He's using blended silk.
And out. She has really good breathing. There's no collapse at all. She's doing really great. That is the toughest injection on the nose as far as pain goes.
That's uncomfortable.
She was really, really, really good with it.
Disciplined.
I don't numb it. No.
It wasn't bad. It just
I wouldn't enjoy it otherwise.
It's annoying.
No, I'm only kidding. Can I have a cleanser,
I
please?
didn't find it was that bad. It was just kind of distracting.
Yeah, there is
distracting.
pressure. There's a little pain and stuff like that. We're going to do this side, and then we'll let her get off the chair and do another patient, hopefully. Okay? Trick is skin into needle rather than needle into skin. I could demonstrate how she would really squinch and not like it if I was to go and inject with the needle pushing it into her nose, but she won't like that. So, we pull the skin back, hold the needle over there, 3, 2, 1. There it is. Feel it? If you didn't, you're dead. Okay. So you feel a little pop like that, and you start to flow very slowly. I'm in between the middle of the sandwich. I'm in the dermis over here, between the two. You're going to breathe it through, girl. That's the girl. I'm going to give you a little bit of product over here. There you go. Breathe in and breathe out. The anesthetic is starting to take effect in the product now, so you're going to be okay, all right? I'll take my hand away so you guys can see, all right? Look how slow the plunger's moving. I'm hardly giving her any product at all. There it goes. It's going to find its happy place and work along. Once I have a little bit of the product in there, you can see that it's progressing a little bit more, and I'll just give her a little bit more over here, and that's it. Look at the blanching. Okay? There's nothing, you okay? Mm-hmm. Good. There's nothing like your alimentary canal being about 2 inches long. Okay? This will pucker your you-know-what. Because you think that you're causing an intravascular injury. You're not. What you're doing is you're putting pressure on that area. And that's why I massage them. And that's why I keep them in my office for about 10 or 15 minutes. You can always high laser yourself back. I haven't had to do that yet. And as you massage, you'll see how the skin color will start to come back.
Huh?
Italian.
Okay? You're a challenge.
Oh, I know.
Is that? You want your lip done? A little in the lip. Should we do a little bit in her lip? Whoa. Okay. There's 2 ways to do a lip. Ken, tell me about the way that you want to do her lip here. I'll do it whichever way you like.
Okay. Well, as we talked, you want to look at her photos when she's
Come on in a little tighter, guys.
she's in her 20s and see what those lips were like.
Remember how much nostril show we had before, guys? Okay, and let's back up a little bit to see her dorsum. See, if I got a result like that from a rhinoplasty, I would be over the top. That's really beautiful. She has really nicely defined domes. See this crease over here? There's a vessel right underneath it. That's going to be the alar artery or the lateral nasal artery that's coming across over here. The alar will probably come off a little lower.
Okay, Len, have a look here.
Wow, good. I want to hear
Yeah,
that.
see, as you know, when you show patients in the mirror right after, there's 3 types of patients. Those that are a light switch, like she just saw immediately the results without even explaining it to her. And the second is the dimmer switch. It takes a little while for them to kind of have to look at it, and then there's a sunrise. Those that takes a while to get home, and the next day they call and say, I see it. So people who are visual and artsy, have a visual brain, usually can see it right away.
When was the regular collagen, or was it porcine collagen? Was it Evolence, or was it bovine? Bovine collagen so long ago?
So long ago.
Because you still have a little fullness over here and there.
Yeah, she does have a little bit.
And how would you like me to inject
See, with time, we're just talking about, if you look at her photos when she's in her 20s, you probably never had much of a Cupid's bow, so that's important to understand that.
I should let you know.
And generally what happens with getting some miles on us, get some little mileage stickers, then the bottom lip often shrinks out of proportion to the top. So the reason you're feeling a little weird is that all these fillers have a little anesthetic in them, so she's feeling feels like her nose is huge. But it's not, it just gives that sensation of being big. So the bottom lip often shrinks out of proportion to the top. So you get that phi reversal, but usually that doesn't happen until you get into your 50s. And now her lip ratio is a little bit off, and she's kind of knows that a little bit because the way she was putting her lipstick on. Did you notice the way she had her lipstick on? She had her lipstick above and below the vermilion, right? So she does that to she may or may not recognize, she may not synapse that, but she's putting her lipstick above and below. Now, have you had any tattooing done here?
Mm-mm.
Okay, that's good. Because she's got kind of a real waffly pattern, and she's got a minefield of vessels up here as well. So we're going to have to be a little bit careful with her. She might bruise here a little bit.
But we're not going to let that happen.
I thought you'd like to know about that.
Thank you. Okay,
so
let me quickly go over the anatomy of the lip so you guys understand what the story is. Because
what I would say,
we're seeing too many lip injuries. Go ahead, Ken.
So one thing you can do, I'm a non-coffee drinker, but I sort of help myself to the coffee sticks here and there. And this happens to be a tongue blade, but it's still okay. And you want to measure that line. Remember the distance, the intracanthal distance, and the width of the nose should be about the same. So that width, the maximum volume of the lower lip should be that intracanthal distance. And if you don't stay disciplined to that, sometimes you can make the lower lip too full. So I would definitely mark that out where that maximum volume is. We need a little bit of eraser there, but here. And we actually draw that out in patients a little bit off there, but not much. So I use cannulas for lips, except for sometimes the lateral oral commissure here a little bit, and sometimes the philtral columns. But I think you want to stay disciplined to keep that volume on her lower lip a little bit in tune with just the phi measurements there. So whatever product you want to use. What would you use? What product would you use? What products would you guys use?
Can't hear. I have Ultra. Ultra going once, Ultra going twice. What else do I have? Give me 5, 10. Velour, I heard.
Volbella,
I've heard.
Volbella Velour.
Okay.
Are we going to use it straight up, or are you going to blend it? Straight up. So what are you trying to accomplish here? Volume, shape, definition. What are you going to try to accomplish? All three, right? You're going to try to create shape a little bit and contour a little bit and reestablish your philtral columns a little bit. The philtral columns, as you get a little miles on us, get a little bit splayed a little bit. So you want to keep those philtral columns right in line with what her philtral column used to be. In older patients, you always inject the medial side of each philtral column. Otherwise, you actually widen it and it looks older. So I always mark out where those philtral columns should be. And then you can inject. I do most of my injections with the vermilion in the sub-vermilion zone. And then you can still create a little bit of volume. But most of these HAs don't like muscle. Right, Arthur?
Correct.
They just don't like muscle. So if you're getting too deep and try to get too much volume, you get a lot of issues with swelling And that swelling is often asymmetrical, and it gets to be a little bit nasty, particularly if you block off some of the mucus glands. So for her, I would use, personally, I would use a blended product. And I prefer that for lips, and that's one of the places I use blended products. And you pre-wet it, and then you have the less swelling, and you can still give them some sublingual Claritin just at the time you start treating them, and that'll help a little bit of the swelling. But that's what I would do. I would do either a blended Silk or a blended Volbella or blended Vollift is what I would do. That's my personal choices. And if I was in Canada, I'd use a product you've never even heard of. So, called Redensity 2. It's a product that is very nice as well. It doesn't cause swelling because it has very little hygroscopic effect. So for orbits and for lips, it's very nice. You'll get that eventually. It's a Swiss product. So that's kind of what I would use, Arthur, if you want to go ahead.
What is it called?
Redensity.
Redensity 2. It's a Teosyal product from Switzerland.
From Teoxane, right?
Yeah, Teoxane. Teoxane Company.
Yeah, Teoxane Company. Teosyal was the name of the product line. Okay, so here's the thing that you have to understand. You have to understand the anatomy of the area of the lip, and you have to understand what your aesthetic goal is. Just as Kent was telling you. Because you have two options. You have lip enhancement, and you have lip augmentation. You have to decide which is which. I don't think I've ever done a lip augmentation on a patient who's 50, 55 plus. I'm doing lip enhancements. If you try to augment an older lip, you're going to get into trouble. The reason is the fact that the lip anatomy doesn't allow for it when they get older. And I'll explain to you why. If you take a look at the superior labial artery, the superior labial artery comes off the facial artery. The facial artery is located 1.5 centimeters lateral to the commissure. It comes off the facial artery, it's deep, and it starts to run across to the lip. But it looks like a dolphin going through the ocean, like this. It has tortuosity to it, the same way that you have tortuosity to the facial artery, but not left and right, but up and down. So it's doing this. It's going from the posterior aspect of the lip, which is submucosal. It's going from there into the muscle, back to the submucosa, into the muscle behind, where the teeth are. Into the muscle, it's going in and out like a dolphin. It is never, ever more than 4 millimeters deep. That's all you got, 4 millimeters. It's not deeper than that. So we're seeing too many injuries. It runs at the vermilion border in the upper lip. So it's doing this in this plane, in the muscle, out of the muscle. So if you're going to inject vermilion border, you must be intradermal, perhaps subdermal with a cannula, but you can't be any deeper than that. If you're going to inject the vermilion of the lip, you must be submucosal or in the superficial part of the muscle if you're augmenting. Okay? You got that? The orbicularis muscle is shaped like the trunk of an elephant. It comes down and it hooks up like this. It hangs like this, the orbicularis muscle. It's what gives you the pout over here of your upper lip. It comes down and does this. As we mature, it unravels. And that's why the upper lip gets longer. Because what happens is it does this. Do women get longer lips than men as they age? Why? Bingo. Hair follicles. The hair follicles are pylons. They're rebars that are inside the lip that are giving the lip structure and not allowing it to drop down. But the women don't have that. Okay? So some women. Okay. So what happens is if you look at a cross-section of a lip in a more senescent lip, in an older lip, it's like this. If you try to put volume in and do a volumization or an augmentation in a patient who's already got a long lip because of the fact that that muscle is unfurled, what you're doing is you're adding volume in. It's going to look like, for lack of a better description, the clanger on the inside of a bell. You know that thing that bangs back and forth? It's going to hang down. It's going to make the lip worse. That's why doing more mature lips in women that have very thin lips is a more difficult task. You can't bulk them up. You have to do an enhancement, not an augmentation. In order to enhance, you go to your product like Restylane Silk or Volbella, and you inject submucosally. And I blend all my products in lips as well, because I'm giving it the water that it's looking for so it doesn't overswell. That's just the way that I do it. Kent does it. Doesn't mean it's right or wrong, guys. It's just the way that I approach the upper lip or the lower lip as well. And I do exactly the way Kent described. I'll either use a cannula or I'm going to use a needle. If I use a needle, I usually use the small BDs because I try to make it as painless as possible. I haven't blocked a lip maybe 7 years. Kent, do you block lips anymore when you do them?
I haven't blocked them for 15 years probably.
There you go.
How do you blend for lips? What's your, the same?
Yeah, when it comes to lips and when it comes to the periorbital region, as I was explaining to some of my colleagues at the break, when I work in this area or I work in this area, what you're doing is you're working underneath super thin skin because the mucosa is modified skin. So you're working under super thin skin. Any little bump, any little swelling is going to show. If you get swelling in a cheek, it's down deep. You don't see it. In fact, the cheek looks a little more wetted. It looks a little more robust. But any swelling in the lip or the eyelids is going to show right away. So when it's an area that I'm worried about swelling, I give the product a drink of water before, or a drink of lidocaine before it wants to, before it's injected. So I inject the wet sponge, which has expanded, rather than the dry sponge. Remember you used to have those little monkeys? You put them in water and you wake up the next morning, you had a big monkey. They would swell up like that. That was one of my favorite toys when I was a kid because I was unusual. Okay? I still am unusual. That's all right. So that's exactly what you're doing. You're giving in the expanded product, the way that I think of it. Okay? That's the way that I do it in my practice. Again, is it right or wrong?
We've got blended silk for you.
Okay. You don't want silk? Is that what you what?
Whatever you want.
Whatever I want. Okay. So we have blended silk, and we have it on what?
That's a 30 half.
30 gauge. He wants me to do it on a
He wants
cannula.
you to use a cannula.
So what we're going to do is we're going to take out some of this. You're going to give me, what size cannula would you like me to use, Ken?
I use the Magic Needle 30 millimeter.
That's
30
what
gauge.
I use too. Now, did I pack any over here?
I saw one there.
Yeah, I had it here somewhere.
Right here.
There it is.
That one, yeah.
Good boy.
Right
Thank
there.
you. Yep. So I'm going to do, let's get her to give us an idea, because I use cannulas and needles for this. Does a cannula belong in muscle?
No.
Does a cannula belong in dermis? It belongs in the plane in between. You know how, it's painful to try to drive a cannula into a dermis or something. A 30 gauge, you might be able to do it.
Now, maybe as you do this, talk about something that they've never seen before, felt before, until they started using cannulas. That's the septi.
Okay. So what happens is that there are little bands that are going from the muscle, the orbicularis, that are going upwards to hold on to the mucosa. Okay, those little bands are called little septi. They've been shown again by Aurora Campesa in the demonstration they did. And very commonly, can you open your mouth just a little bit? Just like that. Perfect. And you'll see it on her over here. Do you see this area right here? Let me turn her a bit so you can get an idea. You see that little notch?
Yeah.
Right where her tooth is? Typically, you'll find one over the medial incisors. Okay? You see that little notch? Sometimes if you ever injected a lip and there seems to be one little notch that you can't seem to be able to correct, and the more product that you put in, the more it wells up on either side, and you struggle. Do you want me to give you a tip on how to get rid of that? I can't. Oh, of course I will.
There's a little trick to get rid of that.
Okay. We're going to see over here. We're
You'll
going to try
feel
this.
those little septi. They feel like
speed bumps.
little speed bumps kind of thing there.
I'm going to clean you up here.
They'll just some people have them and some don't. Sometimes you can't predict, but they just feel a little bit odd.
Okay, so I'm going to do this, as I said.
Usually we measure that. He's going to measure exactly where he's going to go with his cannula, and then he could use the cannula after. So he'll probably go from the filtral column laterally. Yeah, perfect.
We have lots of room here.
There you go.
Okay. Where would you like me to make my port, Kent? Where do you make yours?
I would make it...
Do you make it in the red part of the lip or above?
Oh, just barely above. Just barely above the red of the lip.
I do the same. You're going to feel a small
perfect,
little
right there.
stick over here. Okay? You good? You can go now. Just kidding. Don't let the patients walk out of your office like this. Not because it's unusual. It's because every 16-year-old is going to want one the next day. Squeeze. Well, let me just take off the cannula thing here, over here. Okay. Now we got to find, there we go. We got to find that little hole on somebody who doesn't want to bleed. So we're going to wait a little bit.
And if it's not, has a little show there, and it doesn't wake up a little bit, it just wakes up.
Okay. You feel a little pop.
And you won't like it. It's blunt.
No, it's not bad. She'll be okay now. Okay? And we start the flow of product very gentle. What I'll do is I
didn't want to squeeze those masseters anymore.
Yeah. So I'm just going to talk here for a second. You're comfortable? You're okay? Okay. Can you pan out a little bit? And I want to show them where I'm holding the syringe. Can you pan out with the camera just a bit? Thank you very much. Keep going. Pan out. Pan out. Till I stop. Bingo. Where's the syringe,
right
guys?
there. It's good.
Where's the syringe? At the base of my thumb. Why? Because here I can squeeze. Here I have to push. Squeezing gives you more control than pushing. When you want to be a sharpshooter, they say squeeze the trigger. They don't say pull the trigger. So I'm going to squeeze the product very gentle. I can drop in small little amounts. And I'm gently going to go ahead and advance the cannula. You're going to see a little speed bump over there.
There's a septi right there.
So I'm going to put a little product in just over there to give her the anesthetic, and then I can pop through it. My location is kind of halfway between Vermilion border and the wet-dry junction, letting the product do the work for me. Okay? And I'm going to go right to the middle where it's a little more sensitive, and that's it. I'll now withdraw slowly, putting in some product. And that's it. Okay? A little bit of, now that is all submucosal. Now you'll notice that you don't mash this product. Whether it's Resty Silk or whether it's Volbella that you're using, treat the product like it's your little baby girl. Don't mash it, don't slap it. What do? We don't mold, we
blend.
We blend. And we can blend that a little bit, okay, just to give her a little more bulk, like that. Because remember, I'm going to have to do that lower lip. We don't want the upper lip to dominate. How was that?
Wasn't so bad.
Wasn't so bad. Okay.
See, in forehead with fillers, you do more massaging. And with the fillers you saw before with Dr. Swift, he was blending. And then a little bit of molding. But on lips, you just blend, just like a doll.
If you start the inflammatory cascade, if you really try to mash a lip, those little mast cells that come into the area to say, why is there edema over there? Those little mast cells have CD44 receptors on them, which are receptors for HA, for hyaluronic acid, for the little bits of HA. And that's why we see these angioedematous reactions. Okay? It's also not going to be squished by the muscle because we were in the submucosal plane. So I just take my finger and I run it gently over the lip just to see what the story is. Okay? It's a beautiful little volume that she has on her upper lip. It doesn't look injected. And as Kent has taught me, the reticulated lines of the lip, they'll disappear.
It's like lipstick in a syringe.
Bingo. What I'm going to do is I'll do the other side with cannula, but for those of you who are needle users, I'm going to show you how I would do this if I was doing it with a needle. Is that fair enough?
Yeah.
You're okay with that, Larry?
Sure.
Perfect. So I would take a BD2 syringe, getting all the tricks of the trade here, guys. Good. BD2 syringe. Let's focus in on my syringe over here. Okay. I put my cannula into the syringe. It's a sterile environment in there. And I will gently withdraw it as the product comes back. Right up to the top. Perfect. You can hold that.
How do you get the rest of the filler out of the cannula? Like, so it doesn't get wasted?
That little bit that's in the thin cannula?
Yeah.
You won't waste much.
Okay.
It's not a whole lot. If you're using a 22 gauge, yeah, probably. So we're going to do the lower lip on this side, and I'll use the needle. You're okay? Okay. So what I want to do I want to start the injection from the commissure? Why not? Because the bulk of the product we want to be in the middle 2/3.
That intercanthal distance.
Right?
It takes some discipline not to do that because it's the tendency is to start laterally.
Retract the lip. Flip. How was that? Did you feel anything?
No.
Hardly anything
Not
at
so
all.
much.
Look at my depth over here, guys. You can practically see the color of my needle. Do you see that? I'm superficial.
It's
You don't
sub-vermilion actually
As
right
it's going
now.
to start. Okay? And I'm injecting oh so slow and advancing my needle as I inject. Do you see that? Can I have a dry sponge, please? Where my location? I'm beneath the wet-dry junction between wet-dry and vermilion border. Okay? I inject very slowly. I remove the needle. I wait a second or two. She's now anesthetized in this area over here, so I can go back and do that. She doesn't even flinch or move. Doesn't feel it. And then I'll inject again, slowly advancing. Okay? I'm checking the color over here. You can check up at the glabella too if you want to be sure. Anti and retrograde injection, nice and slow. And that's the way that I would start to do the lower lip. Okay? We'll give her just a little more bulk over here. Last little flick. There we go. And a small amount of product. What you want to do is you want to create that little bee sting on the bottom. Okay? Little pressure. We're going to take our little arnica again, and we're going to gently massage. Not massage.
Blend.
Blend. Ken taught me that too. When I was using these products originally, Volbella and the Silk, every now and then I get a patient that would call me like 12 hours later, 15, 16 hours later and say, my lips are swelling like crazy, right? What you do if that ever happens, by the way, is just give them one pulse of steroid. Usually 30 milligrams of prednisone and it all settles down. It'll settle down by itself in 2 days, but you want to get rid of it pretty quick. And then you just blend, you do a gentle blending like that. Close your mouth. There we go. Okay? And we'll do the same thing on the other side. We can use a cannula on the lower lip and we can use a needle on the upper lip, whatever you decide. Bruising wise, if you take your time, you should be fine. She has a bunch of vessels. We're not going to bruise her. What I will show you is, can I have that little needle again, please? There's stuff still left in it.
A little tiny bit.
That's all I need is a teeny tiny little bit. Open your mouth just a bit. Okay. No, that's okay. You can close it down. Look
Right
at this
there.
little notch there. Do you see it?
Yeah.
Okay. If you try to go in from the side, it's like pushing against the closed door. You can't do it. The stuff is going to bulk up. If you try going in from the other side, you're pushing against the closed door. So where am I going, guys? Right at it.
Vertical.
Vertical. Okay? So if I want to correct this little depression over here, what you actually do is you pop it in underneath the mucosa, you press, you do a small little injection. You with me on this? Good. You almost can hear the, like Kent was talking about, you hear that little bubble wrap pop almost. So we're going to do that just for this little area right here.
Shouldn't bother because it's already got some anesthetic in it.
There we go. I'm just underneath the mucosa. I put in a tiny little bit of product, and I pop out that little thing. It's gone.
Disappears. Voila.
Okay? If you try to get it from the side, you'll be bulking the product up. So don't do that. Okay? We good?
You thought Walla was French, didn't you? Or didn't you? He's French. You think you invented that word, Walla?
Voila. Voila.
It is French.
How you doing? Okay, so we haven't given her any type of EMLA or any type of local anesthetic. I've already primed her for pain by doing her nostrils over here. That was about as bad as it gets. If you were to grade from 0 to 10 how we've been doing the lip, it's what sitting? Give me a true number.
I think the cannula is worse. Well, maybe because it's my upper lip.
No, the cannula is worse because you feel the popping as you go along with the cannula. No question about it.
What about 3?
About a 3 with the cannula and with the needle?
1.
A 1. So the needle, I find also, it's just a question of the patient sort of feeling a little skittish when they feel the little popping. I'll stick with needle if you want, if you prefer. Okay. I'll do the other side of the lip with needle just to show you that you can get the same result. But it's the technique on how you put the needle in, guys. Okay? refine your technique. Remember what Bob was telling us about. Just make one little adjustment in your practice. Kent and I have patients that come to see us because they say, I hear you do lips and it doesn't hurt. A lot of people, what's the number one reason why most people won't have their lips injected? Because they want to get it injected? It's fear of pain. Number two is their fear of having an unusual look. Take out your calipers, measure. That will get them confident that you're not going to over-inject them, and tell them you're going to use a technique that's going to be minimal in pain. Can I have the needle again, please?
Okay, we got blended product here, so you're
Yep.
fine.
We're good? Kit. Is the 30 gauge cannula just like a needle? He's asking the question to you.
No, it's still
bubble in
blunt, and it slides very well. I don't use it. I use more on 27 gauge, but I do particularly like this French
No bubble now.
needle, the magic needle. That's
put
a
a little
30
more in?
millimeter length. It's just about the right length,
Yeah.
and 30 gauge.
What's this?
We've used hundreds of them.
So give me you have
But
another. Here we go.
it's a little wimpy, so I use more and more 27 gauge for
How do you
lips.
prevent those
I use
bubbles?
25 gauge for most other places, but
Touch
the
the
lips I still use either a 27 or a
Get it all
30.
the way. Take a look
But
at
it's
the
not like a
instrument.
needle.
You have to start.
You got to
like
remember,
that.
you're not being a blacksmith. This is a doll. Everything's done really, really gentle, and you have the right. And all these fillers, I think everybody learns how. It's like if anybody golfs in the room, you know what a sweet spot is. So it's all fillers have little sweet spots. So if you get the little sweet spots, most patients don't hardly feel anything. So it's just it's a matter of technique.
At the end of the rim, you mean? The whole nose?
Yeah, your nose is going to feel a little wonky for a little bit because of its
Okay, but it looks
all that
fine.
anesthetic there.
Vascularity is perfect. It's not a problem. Okay, so if
here
we
we
do
go.
the upper lip, I have to start from about the commissure because I want to give vermilion from border to border. I retract the lip, flip it back in. I start my flow of product very slowly. You're okay? Don't have to nod your head. You can just say yes if you
Yeah,
nod.
with noses and with lips, you can do a lot with having the opposite of what you think. Instead of injecting, have the nose inject itself and the lip inject itself just by retraction. It doesn't make a lot of sense, but it's just the reflexology of it is such.
Do you see the depth here, guys? I'm just submucosal. Can you see almost the color of my needle? Do not put Restylane silk, do not put Volbella into the muscle. It will bite you.
It hates it.
It hates it. It doesn't like to be squeezed. And because it doesn't like to be squeezed, as we'll see when we do tear troughs, I'll show you the technique that I'm using on tear troughs. It doesn't like to be squeezed because then it'll start to form nodules on you, perhaps 6 months down the road. The product gets bunched up. Doesn't like to be squeezed like that. If you put it in the submucosal plane, let the muscle do what it wants, the product glides over the top. There we go. Good girl. When I'm in the submucosal plane, I can't be inside the artery. Okay? It takes me longer to do lips than it does to do half a face. Why? Because I'm injecting slowly and I want to make sure the patient doesn't have pain. That doesn't mean it takes me an hour. But what I want to also make sure of is while I'm doing it is that I get the symmetry. So lips take me longer because I fuss with them a lot. If you're off by a millimeter on a lip, your patient will be back the next day. They'll say, I have to adjust my lipstick to make my lips the same. Don't you agree with that,
Oh,
Ken?
absolutely. Yeah. Definitely each side of the lips you want to be twinned. Upper and lower balanced.
How you doing?
What do you think about our filtral columns
Sorry?
there?
You don't even feel it. You're
What do you
just being
think
nice.
about our filtral columns there?
Can I have a
Sometimes if
little
you
bit of yarnica?
don't do a little bit of filtral columns, it makes the lip like it look like a uni lip.
You have a picture of yourself when you were younger? That's the thing
Yeah.
that I learned from Kent is like I get the pictures of patients. I have a little bit here, thank you. I'm still walking around with this stuff.
She's got a little bit of a filtral column there, not much, but a little tiny bit. But she's also got a minefield right there to the right of midline.
So if they don't have filtral columns when they're younger, don't do it.
Yeah, I agree.
That's
I don't
what
do it.
people will notice that there's something different about them. You don't want different. You want better version, right? Like Kent says,
You want a biomimicry of what they used to look like. I think we're all aware of that.
close your mouth. Okay. Good. We have to do the bottom part of the lip, and we're going to be fine, okay? You're doing great. Let me have the needle again.
The
We'll just,
disadvantage of her lips is her genetics. That's why I thought she had a little bit of tattoo in here, because she's got the vermilion. Remember, is the zone where you put lipstick. So her upper vermilion towards the cutaneous zone here, towards the ergotrid. The ergotrid is the zone above the lip from the nasolabial fold across. Is that whole cutaneous zone. So where the vermilion meets the ergotrid here, it's uneven. It's a little unevenness. That's why she probably has trouble finding lipstick that works well. Do you have trouble finding lipstick? Yeah. So you have to use some of the lipsticks like Superstay. Have you ever used those, Superstay? Like Maybelline makes that. Maybelline makes the good. Oh, it's true. Maybelline makes a good, and use it. It has a little. How many have used that product? It's very good. And they have lots of different colors now, and you can.
We're done.
I'll go shopping with you. We'll go buy some Maybelline.
Maybelline?
Actually, I buy most of my wife's clothes. Don't laugh, because she's a smart girl, but she doesn't have a good eye. So I usually buy most of her clothes. You would not get away with that.
Are you kidding? I don't buy any of my clothes.
Oh well, no.
Everything is vetted out before I even try it on.
Now, the reason I like ultrasound gel is there's no calories in it.
There's no calories. There you go. She's been unbelievable, guys. She really has been unbelievable.
I know it tastes bad, but there's no calories in it.
Boy, you really went ahead and gave her the gel there. Okay, close your mouth here for a second. Okay.
Just open your mouth just a tiny, tiny bit.
That, by the way, that little brown thing over there is not a bruise. I wasn't there. That's just her little thing that she has over there. Give me a pucker.
Yeah.
Oh, that's beautiful. It's really nice. So subtle is the name of the word, the way that I do it. It's always easy to add stuff in. Allow the product. It's going to swell. Allow the product to do the work for you, and then you can add it in. By the way, every lip injection that I do, I bring the patient back at about 3 weeks to 4 weeks, check them, and I almost always add in a little bit more with a BD2. Why? Because the studies have shown that if you put a second injection in, you increase longevity of the product. We were seeing products that were lasting up to a year, 18 months because of the second injection. It's almost as if the body says, I've had it, okay, I understand, you're putting product in, and they maintain it. And I can show you pictures of patients that I've been injecting lips that I haven't touched their lips in 2 or 3 years. The other thing that I used to do on every single patient when I was injecting them for a lip augmentation was what? Something you guys probably think outside the box here. Come on, let me see if I can change a little something that you do in your practice. You have a 24 or 25-year-old that comes in that wants to have her lips done. She's got the bulk that you can really augment her. You want to go ahead and use a product that will not so much mind being in the muscle. So I'll go to a product like Restylane or Ultra Plus. Okay? I'll stay in the upper third of the muscle, meaning I'm not going deep to try to get that artery involved. But what else am I going to do to the upper lip? What? Absolutely. Why? You're going to use Botox in the upper lip. And the reason that I put in microdoses of Botox, even in young patients, is because it softens the pursing action and the shearing action on the product. I never published it. I should have. But I was taking results that were 4 and 5 months long and extending them to 9 and 10 months long. And if you do that, it costs you nothing with a half unit of Botox or a little bit of Dysport or a little bit of Xeomin. And what will end up happening is that patients will say, wow, this guy injected my lips. Not only did it not hurt, but it's lasting longer than when I was at the other guy. I mean, patients love to come and see me. I mean, that's fine, but they don't want to come and see me every 4 months to get stuck in their lips. Nobody looks forward to that. So I was injecting small amounts of toxin, just a millimeter or two above the vermilion border, into the dermis. Usually a half unit of Botox, or maybe something like a unit and a little bit of Dysport, or a half unit of Xeomin. And the results were much longer. In fact, We haven't had the opportunity to do a barcode, but you heard about the Meso-Mix that I started talking about several years ago that people said, the guy's a heretic, don't listen to him. Don't. But think about this. You have a patient with a barcode, lines of the upper lip. You ever struggle with that? Come on, that's one of the more difficult things to treat. If you inject into the actual lines, you get this picket fence. So what do I do now? I started injecting with cannulas, and I was running the cannula underneath the white part of the lips, nice and slow in the subdermal plane, and I was putting in a little bit of filler and doing some subcision at the same time with the cannula, because all those little septa are coming from the muscle up to the skin. And then I would go and I would reach for my toxin, and I would inject my toxin in to soften the crunching of the lip, the pursing of the lip, right? Where was I putting my toxin? Same place, subdermal. So what did I think? Why not mix it together? Bingo. So we're going to do that hopefully tomorrow. I'm going to blend in a little bit of toxin into a product. How many units? How many units would you use on an upper lip? Let's talk about Botox. How much of Dysport? 10. So whatever you would normally use, you blend that into your product. You take out a little bit of the product into another syringe. Okay, I use it with a cannula. And I'll put in 0.2 usually cc's of product and 0.2 cc's of 50-50 blend on either side of the upper lip, coating the whole thing. And each 0.2 cc's has 2 units. So I'm totally 4 units over here, and I'm coating the entire muscle. I'll show you results. Maybe I'll pull them out for you tomorrow if you like, that are now 29 months. Not eradication, but definitely a huge improvement.